My breast cancer journey began in November 2006 when I was diagnosed with 100% hormone receptor positive breast cancer. I actually had my cancer on one breast in two different locations. So it was determined because of the size of the tumors that I would have to undergo a mastectomy. So I met with my oncologist and landed up having some treatment prior to the mastectomies. So I had the luxury, I guess, of researching a little bit. But as you can imagine, when something like this happens to you, you don't know what to think, you don't know what to turn, you don't know what's right. I asked the oncologist, where do I go from here? She said, well, you would see a plastic surgeon to explore your options. And that's when I met Dr. Teresa Buescher. Met Dr. Buescher probably 3 months before my actual mastectomies. And I met with her for about an hour, and she showed me implants, different kinds. I asked if there were any other options. She said, well, there is a procedure that I do called the deep flap. I inquired about that, and initially it was overwhelming, just an unbelievable amount of information for me to grasp. She took her time with me on more than one occasion, because just that one consult didn't answer all the questions I had. But ultimately, I decided that the deep flap was the way to go. And in retrospect, knowing now what I didn't know then, I'm a real scar builder. So I think having something that is me, in me, making these new breasts, was the way to go. All through the procedure, both Dr. Buescher and her staff helped me along the way with any questions that I had at all. Recuperation was lengthy, but when I look at the mirror and feel myself complete, it was worth every bit of everything that I went through. I'm very much a supporter of helping women with breast cancer become familiar with the different options that they do have. I can't say enough about Dr. Buescher and her staff and the experience I had. They made my journey much easier.
My name is Teresa Buescher, and I'm one of the plastic surgeons at the University of Kansas Medical Center. And I'll talk to you a little bit about some of the different forms of breast reconstruction that we have today. Everybody knows about breast implants, and so we really won't talk about that. But what is more newsworthy really are the sources of soft tissue that we can take from other parts of your body that can become permanent reconstructions for you and won't necessarily cause large functional deficits, so that you should still be able to do things normally, like running, jumping, bouncing, bicycling. Some of the soft tissue flaps that we used in the past would leave a relatively significant deficit in terms of function, and so people would tend to shy away from them because it's not good to have a breast, yet lose 25% of your shoulder strength, or not be able to do a sit-up, or have to change how you get out of bed. But modern techniques these days have really taken care of quite a few of those problems. One of the newer techniques is something called the deep inferior epigastric perforator flap, and it's probably the easiest way to think of this is a third generation tram flap, or transverse rectus abdominis myocutaneous flap. Think about the tram flap as the tummy tuck flap that was used to make breast reconstructions starting in the late 1970s. The downside of that was that it took the whole rectus muscle, and you had quite a bit of functional deficit on the abdominal wall. Certainly if you did both sides, the patient couldn't do a sit-up, couldn't do things normally, would have to get out of bed differently, get out of a chair differently. The deep flap doesn't take the muscle with it. The deep flap is basically taking the pattern of blood vessels out of the muscle and leaving the muscle behind. The concept is that you can take a very large blood vessel and you can test it and make sure that it provides the blood supply to the skin and fat that you want. Then you can follow that blood vessel through the muscle, separate it from the muscle, pull it out and close the muscle back up, and the muscle will function actually very well. Certainly enough for running, jumping, bouncing, playing baseball, riding bicycles, things like that. And then that blood vessel can be hooked up to a blood vessel by the sternum called the internal mammary vessels, or to a vessel in the armpit called the thoracodorsal vessels. And then that tissue will live based on the blood flow coming from those blood vessels. So you can have a very nice reconstruction and not have the functional deficit that some of the older techniques used for you. So the deep flap is a very nice operation. Another operation that can be used for ladies that are very thin and don't have enough tissue from the abdominal wall would be something called the transverse upper skin palagracilis flap, or the tug flap for short. This involves using a muscle from the thigh that really isn't used very much. It's called the gracilis muscle. It lets you pull your thigh back into the midline, but other muscles exist that are much stronger than it is, so it's not really functionally necessary for running, jumping, bouncing, riding a bike, that sort of thing. But it does give the blood supply to the skin and fat of the upper thigh. So you can use the skin and fat of the upper thigh together with this muscle and make a breast mound for a little skinny girl that doesn't have anything on her abdominal wall. So between these two operations, we can provide nice soft tissue reconstructions and not cause a big functional deficit. And you might say, well, then why do I want soft tissue? Because it's permanent. Because once you're done, you're done. It'll last the rest of your life. If you're going to live another 40 years, it's going to live another 40 years. They're soft, they're warm, you can lay on them, they're just they're no foreign body, they don't get infected. If there are wound breakdown problems, you just put an ointment on them and take a shower and they're just going to heal like any other part of you. So there's a lot to be said for the soft tissue reconstructions, and certainly maintenance over the rest of your life is very, very easy, much simpler than what an implant would be. So those are the two big ones that we do here at the University of Kansas. But of course, there are other things that can be done too. You can have implant reconstructions if you'd like, and there's certainly nothing wrong with them. But the soft tissue is probably our forte, that we do here, that makes us a little bit different from other hospitals. Well, I think it's still estimated that about 1 out of 8 women in the United States will get breast cancer, and you don't have to have your breast to live, but it's a lot easier to have a breast or to have something in place of the breast to be able to look normal, to be able to feel normal, to wear clothing normally without having to shove stuff into it. If you have reconstruction, you just stick your bra on and go. You can sort of kind of forget about that part of your life, or at least put it on the back burner and not have a constant reminder that something was wrong. So I think it just helps people get back to what they want to do and lets them have a return to a more normal life. I would highly recommend it. I've had several patients that come in even 15, 20 years after their mastectomy. They thought they didn't want reconstruction, but guess what? Clothes don't fit. They get tired of having prostheses that move around. I had one patient who was a teacher. Every time she wrote on the blackboard, the prosthesis fell out. So it's like, great, 15-year-old boys are watching her prosthesis fall out. It got to be a real drag for her. So I think reconstruction just makes your life easier, and it's just simpler. You can just get on with things. So.